Hello, and welcome to the Early Childhood Health Consultations April webinar titled Understanding Asthma. My name is Maria Morgan, and I'm the project manager with our team, Early Childhood Health Consultation. We are so excited to have you join the conversation today. The Early Childhood Health Consultation Program is in partnership with the Wisconsin Department of Children and Families, housed at the University of Wisconsin-Madison School of Human Ecology, and funded by the Preschool Development Grant. Our program's mission is centralized around supporting Wisconsin early childhood education, or ECE, providers in helping address health-related questions and concerns and offering guidance on best practices. Our program envisions a sustainable and statewide model working through health consultation and improving the quality of Wisconsin ECE programs' health and safety practices. Centrally, we envision promotion of health and well-being of children across Wisconsin. The Early Childhood Health Consultation Program acknowledges the American Indian tribal nations across Wisconsin and commits to a partnership in addressing their questions and improving tailored support to best meet each need of each tribal community. For today's conversations, we'll begin with an introduction, have time for centralized content, question and answer, and a few closing remarks. A few logistic reminders here in the Zoom webinar platform. You do have access to a chat feature found at the bottom. This is a great place for you to enter your comments throughout the presentation. Within the chat feature, you can drop down and send your chat message either to the hosts and panelists or to everyone. We also have the Q&A feature enabled. You are welcome to enter your question here throughout today's presentation, and by selecting the box, you can also send it anonymously. At this time, I'd like to pass it over to Early Childhood Health Consultation Program Director, Dr. Deepesh Nazaria, to talk more about today's session.
Great. Thank you so much, Maria. Again, thank you and welcome to everyone. Pleasure to see you all here, whether you're here live or watching this later on a recording. Today we'll be covering the important topic of asthma. Asthma is something that is very frequent in young children, so we'll understand something about the basics of this, think about ways to communicate with parents in terms of myths or misinformation that's out there, a little bit about the common medications and how to administer them, and then, of course, where you can find other information. Our speaker today is Dr. Sima Ramratnam. She is a assistant professor in the Department of Pediatrics right here at UW-Madison and specializes in allergy, immunology, and asthma. And we're so pleased that she's joining us today. Dr. Ramratnam, take it away.
Thank you. I'm going to just pull up my slides here. Are you seeing the right form?
Yes, we're seeing the title, What is Asthma? And the image at the bottom there.
Oh, there we go. This is
the title, yes.
All right. So I want to thank Dr. Nazaria and Maria Morgan for inviting me to talk about childhood asthma today. And thank you to everyone in the audience who's taken time out of their busy days to listen to me speak about asthma. It's definitely an honor to be here today. All right. So today, I plan to review what is asthma, what causes asthma. I will make mention of a few different varieties of asthma, review asthma triggers and what an asthma treatment plan is. I will talk about asthma medications and the goals of asthma treatment. And then last but not least, share with you a phenomenal resource called SAMPRO, developed here at UW-Madison for nationwide use. And SAMPRO stands for School-Based Asthma Management Program. So let's start by talking about what asthma is. In order to do so, we must first talk about what the normal lung does. Inside the lungs are some tubes called airways or bronchial tubes. When we breathe in, air moves down the trachea or the windpipe through the bronchial tubes. And at the end of each airway are tiny sacs that fill up with air like balloons. Asthma is a chronic disease. Chronic means long-term, involving the airways in the lungs that cause breathing problems. Asthma is not contagious. It is caused by inflammation in the lung. So when a child has asthma, there is always a little swelling or inflammation inside the airways with and without them having symptoms. People with asthma have sensitive or twitchy airways in their lungs. And when something bothers their airways, they then have trouble breathing. Their airways react to things that don't bother other children, and asthma can make changes within the airways, all of which narrow the airway, making it difficult to breathe. So this picture here in the center illustrates how an asthmatic airway differs from a normal airway. You can see a normal airway on the left has a nice wide airway opening with normal amount of muscle inside, no extra mucus, and the air moves freely in and out of the airway. The inflamed asthmatic airway on the right has tightening of the muscles that surround the airway, extra mucus, airway swelling and narrowing, and it's hard for air to flow through this. All of this is caused by inflammation, which results in asthma. So again, an asthma airway, it's harder to get air in and air out because of the tiny muscles around the airways pinch it really tight. There's also a lot of swelling inside the airways, and more mucus is made because the bronchial tubes, inside the bronchial tubes, making it harder to breathe. Oops. So what does asthma feel like? It can feel like wheezing or a whistling sound when the child is breathing, coughing, chest tightness, or feeling like something is squeezing or sitting on their chest, or shortness of breath. These symptoms can be relieved and controlled with medications and from staying away from things that make the child's asthma worse. So much research is being done, and a lot of it at the University of Wisconsin, to understand why some people have asthma while others don't. I myself have spent much of my research career thus far studying environmental risk factors related to childhood asthma. We know that there are certain factors that present a higher risk to developing childhood asthma. And what we are starting to understand is that asthma is a breathing condition that results from complex interactions between many environmental and genetic influences. Some of these influences are allergies. Having allergies can raise your risk of developing asthma, and environmental factors. People can develop asthma after exposure to things that irritate their airways. These substances include allergens, toxins, fumes, and second or third-hand smoke. These can be especially harmful to infants and young children whose immune systems haven't finished developing. Sex is another factor. Boys tend to have more childhood asthma than girls. After puberty, it switches. And then genetics. If your family has a history of asthma or allergic diseases, you have a higher risk of developing the disease. And respiratory infections. Certain respiratory infections like respiratory syncytial virus or RSV or rhinovirus can damage young children's developing lungs. So some children have intermittent asthma. This asthma comes and goes, and these children can feel normal in between their asthma flares. Most times what flares asthma is a viral infection, so they may be happy and healthy in between their colds, but when they get their colds settle in their chest and the symptoms persist, and that's intermittent asthma. Persistent asthma means that a child has the symptoms much of the time, but symptoms can be mild, moderate, or severe. Asthma can be adult onset, but we know that most asthma starts in childhood. Exercise-induced asthma, this type is triggered by exercise and is also called exercise-induced bronchospasm. There's occupational asthma. This type of asthma happens primarily to people who work around irritating substances. And lastly, cough variant asthma is a type of bronchial asthma in which the main symptom is a dry, non-productive cough. I also want to mention that children with cough variant asthma do not have classic asthma symptoms, such as heavy breathing or wheezing or shortness of breath. They may not have, what you think of as having an asthma attack. Because of this, cough variant asthma is usually diagnosed very late, with the consequence of the child having symptoms long-term. And in addition, the child may have received unnecessary courses of antibiotics and cough syrups. And cough variant asthma is actually a common cause of chronic cough in children, which is a cough that lasts longer than 4 to 6 weeks. Coughs with asthma occur during the day or night, and cough in children with cough variant asthma gets more cough after exercise or when exposed to asthma triggers or allergy-causing substances like dust, smoke, deodorants, or perfumes, cold air. And nighttime coughing disrupts sleep in children with cough variant asthma. So next, I want to talk a bit about asthma triggers. A trigger is something that makes asthma worse. An allergic trigger can cause someone to sneeze, itch, cough, or wheeze. Triggers are everywhere, but they can be different from person to person. Sometimes a child might actually have a mild reaction to a trigger one time and a severe reaction to the same trigger another time. So what can trigger an asthma attack? Allergies can make asthma worse. Allergens affect the immune system and cause allergic reactions and asthma symptoms. For example, some allergies include allergies to pollen, dust mites, mold, and animal hair and dander can all cause asthma symptoms. Irritants can also make asthma worse. Irritants don't cause an allergic reaction, but they can irritate the airways and cause asthma symptoms. For example, some irritants are smoke, exercise, colds or upper respiratory tract infections, weather changes, perfumes, or strong smells can all make asthma worse. So I want to talk about asthma attacks. Some people call them flares, other people call them exacerbations, but these words are all synonymous. And so asthma triggers can cause anyone with asthma to have an acute or sudden asthma attack. When someone is having an asthma attack, it is hard to get air in and out because the tiny muscles around their airway pinch very tight. And so during an asthma attack, the airways swell even more and can produce extra mucus, and there's twitching of the airways. And all of this narrows the space for the air to move in and out of the lungs, and this makes it harder to breathe. Asthma attacks or flare-ups or exacerbations can be scary, both for the person having it and for anyone who's seeing it happening. Knowing how to handle the situation can be a big help, and we're going to review that today. So you can catch asthma attacks before they worsen because they usually begin with minor symptoms. Doctors call these early warning signs. But during an asthma attack, the child may have more cough, wheezing or whistling in the chest, have increased work of breathing, so they're working hard to breathe, having trouble catching their breath. The child may have trouble speaking full sentences, have tugging of the skin around their collarbone or their ribs that pulls with each breath, or you may see that they're belly breathing or their nostrils are opening wider than normal. These children may be having difficulty sleeping, and the child may feel or look more tired. And children may often have a cold. Viral respiratory tract infections, again, are a number one reason for triggering asthma attacks in children. It's one of the most common causes. So sometimes asthma symptoms may fail to respond to the use of quick-acting rescue medication like albuterol, but the key to stopping an asthma attack is recognizing and treating an asthma flare-up early. The child is also at greater risk of having another flare-up for several days after having their initial flare. So the biggest risk factor we know for having an asthma attack is the history of having an asthma attack. So what to do during an asthma attack? First, you should locate the child's asthma action plan and refer to the yellow zone in the asthma action plan and give the child 2 to 4 puffs of the quick relief medicine, albuterol, or as directed in the yellow zone. And we're going to be talking in detail about asthma action plans today. Next, you should inform the child's parent that you had to administer the rescue medication to the child. And if the child responds well to the rescue medicine, you can continue to use it as needed. However, if the child's condition does not improve, please ask the parent to call the child's doctor's office for further assistance. So how do we treat asthma? We can use medicines to treat asthma. You will have an asthma action plan to tell you what medicines to take, what medicines the child should take, and when to take them. And you should think of this as a traffic stoplight. So why do we have asthma action plans? Asthma action plans help the adults in the child's life manage the child's asthma. Everyone with asthma should have an asthma action plan. An asthma action plan tells you which medicines the child should take and when the child should take them based on their asthma symptoms. We tell parents that the asthma action plan should be kept in a very visible place, such as on the refrigerator, and the child's doctor will provide the family with an asthma action plan at every visit. Basically, the asthma action plan provides daily step-up and emergency treatment for the child's asthma. For example, green means go. The child should keep doing what he or she is doing. This is their daily medication, and the child is in this part of the plan when their breathing is easy and good. The child is not having any coughing or wheezing. The child is sleeping through the night. The child can play or do sports without any problems breathing. Still, in the green zone, it's important to recognize which students require albuterol prior to activity before gym or recess or increased activity at school. Some children have increased asthma symptoms, such as more cough, wheezing, or shortness of breath, versus students who have asthma but don't always need albuterol before activity. The yellow zone means slow down. The child should be following the yellow zone because the child, parent, or you have recognized that the child's asthma is flaring up and they are at risk for an asthma attack, and stepping up asthma care here is warranted. The child is in this part of the plan if he or she is having some coughing, mild wheezing, shortness of breath, chest tightness, or coughing at night. And red means stop. This is when you or the parent should call your doctor or 911. Some signs that the child might be in the red zone are that the lips or fingernails are turning blue, the child does not respond to you, the child's skin is sucked in around his or her neck or ribs, the child is having trouble walking or talking due to shortness of breath, or they're breathing fast and hard, they're having lots of coughing, their nose is flaring wide, the child is hunched over, and especially if the asthma quick relief or rescue medications are no longer helping. All right, so next I'm going to talk about some asthma medications. So there are two types of asthma medications. There's controller medicines and quick relief rescue medications. Controller medications are medicines that are used to prevent symptoms of asthma and should be taken every day, even if the child does not have asthma symptoms. Controller medications do not relieve sudden onset of asthma symptoms, but they're working to decrease the inflammation of the airways. So these medicines, again, reduce the inflammation that results in asthma, that is the swelling and mucus in the airways, and prevents the tightening of the muscles that make up the airways. And some examples of this are Flovent, Symbicort, Advair, Asthmanex, and Singulair. And there are others as well. The second type of asthma medicine is called a quick relief or rescue medicine. These medicines are used to treat acute or sudden asthma symptoms, such as coughing, wheezing, or shortness of breath. They work by relaxing the muscles in the airways, so it's easier to breathe. Albuterol works quickly and is very important to have during a sudden asthma attack or increased asthma symptoms, but this medicine should only be used when needed and not as a daily medicine. It also doesn't work to decrease the inflammation in the airways. This is why that controller medication is so important. Some examples of quick relief or rescue medications include albuterol, Proventil, ProAir, Ventolin, and Xopenex. Asthma medicines come in different forms. The child's doctor will decide which form is right for the child. For example, nebulizers are machines that deliver asthma medicines in mist. They require tubing, a mask, and access to electricity. Asthma medications also come in the form of an inhaler. Inhalers come in dry powder inhaler or a metered dose inhaler. If your child is prescribed a metered dose inhaler, it's important that they use a spacer that attaches to the inhaler and helps to make sure the medicines are delivered to the lungs efficiently. We'll talk more about that now. So this metered dose inhaler, this is a picture of an inhaler. has been a mainstay in the treatment of asthma since its introduction in the 1950s. It's the most commonly prescribed delivery system for administering inhaled medications for asthma. And however, the effective delivery of medication from a metered dose inhaler is very technique dependent, and the correct coordination for actuation, which is the puffing of the medication, and inspiring the medication is crucial and can be difficult for young children. So in the asthma clinic, device technique should be assessed during every clinic visit to ensure that optimal use and drug delivery is happening to the lungs. But this doesn't always happen because time runs out or parents decline the review. And unfortunately, up to 2/3 of patients and healthcare professionals who administer metered dose inhaler treatments don't use proper technique. But the advantage of an inhaler is that there's the ability to multi-dose, so to take repetitive doses quickly. It's portable, low cost, and the inhaler in combination with a spacer or aero chamber is actually the most convenient and cost-effective way to administer aerosol medications for most patients. So this is where the spacer device is very important. When used properly, it can substantially improve the delivery of the medication from the inhaler to the lower airways. And the addition of the spacer actually corrects for poor inhaler technique in most patients and also allows for faster resolution of symptoms in children with sudden onset of symptoms from their asthma. And lastly, the spacer markedly decreases the drug depositing in the child's mouth or throat and reduces both oral and systemic side effects, especially when they're using it with a controller medication, which are low-dose inhaled steroids. So oftentimes parents ask me, what is better, the inhaler or the nebulizer? Many clinical trials have indicated that the administration of rescue medications, such as albuterol during sudden asthma attacks via inhaler and spacer together is as effective, if not superior to, the delivery of medication by the nebulizer in reversing the narrowing of the airways in infants and children because of an asthma attack. So in general, I recommend the use of spacer or and this valve holding aero chamber for all children, no matter how young or old they are. Now, it's important to remember to clean the spacer. So periodic cleaning of the spacer is recommended, even though the powder residue that's deposited in the chamber is not harmful. One interesting thing is that when the plastic spacer is cleaned with water, an electrostatic charge attracts the aerosol particles in the first 10 to 20 puffs, which actually reduces the drug depositing in the lungs. So we actually recommend washing the spacer in a dilute solution of dishwashing detergent without rinsing afterwards with water to decrease that static charge and to continue that drug delivery down to the lungs. And another important point is remembering that an inhaler is empty is so important. It's important for the patient to have a means to determine when their canister is empty. It's not possible to determine when the inhaler is empty by shaking it because there's propellant in there that remains in the canister after all the medication has been used. And many inhalers now come with a dose counter, but still not all. So oftentimes we still recommend that the parent or the adult just takes note of how many puffs have been used. And also the pharmacy will drive what the insurance will cover. So this is a video from the CDC on how to use an inhaler, MDI, with a spacer. And because inhaler technique is just so crucial to asthma management, I thought that we should watch this video together.
Using a metered dose inhaler with a spacer. Take off the inhaler cap and make sure the mouthpiece and spray hole are clean. Shake the inhaler 10 to 15 times. Put the inhaler mouthpiece into the end of the spacer. Inhale a deep breath and breathe out all the way. Hold the inhaler and spacer between your pointer finger and thumb. Put the mouthpiece of the spacer in your mouth and above your tongue. Close your lips around the spacer. Tilt your head back a little bit. Press down on the inhaler one time and breathe in slowly and deeply. Breathe in all of the air you can and hold for 5 to 10 seconds. Open your mouth and breathe out slowly.
So this is a short video. It's only 1 minute and 10 seconds, easy to reference. And I will include the link with all the resources at the end of this lecture to all the participants. So these are the next 3 slides I have here are actually just written instructions on what you just saw in that video from the CDC. Again, the technique is just so important. What I tell my patients is that it's not that difficult for us to prescribe the right medication for asthma. The parents actually have a harder job at home. They have to remember to administer the inhaler twice a day to the child, know where their asthma action plan is, follow the asthma action plan, which sometimes is, can be a lot when their parents are learning how to manage asthma in the beginning. And they have to communicate with the schools and all the caregivers the child may have. So one thing I've learned is I used to do an outreach clinic in Rockford, Illinois, and I didn't have very many nurses there. So I did my own asthma education, and it was really eye-opening when I would meet with the families and do, make their plan and prescribe all the medications, that I would review the asthma inhaler technique. And almost every single person would have it wrong, even though they so confidently told me beforehand that they knew how to use their inhaler. And so, again, I just want to encourage you all to reference that video and take a look at these slides if there's any question. But some highlights here are priming the inhaler. So especially if the inhaler is at school and it hasn't been used in several days, prime is just a fancy word for shaking it and spraying it into the air up to 4 times. And then you put the spacer into the inhaler and then shake this for 5 seconds to kind of mix everything together. And you want to put the mouthpiece between the teeth and make sure there's a nice seal. So close the lips tightly around the mouthpiece. Make sure the tongue is not blocking the opening of the mouthpiece of the spacer, and then press down on top of the canister with your index finger to release the medication. At the same time, breathe in deeply and slowly through the mouth until the lungs are completely filled. So this should take about 3 to 5 seconds. And this is the part where actually, if the patient is breathing too quickly, they'll hear a whistle from the chamber, and a whistle is bad, actually. So if you're hearing a whistle, you want to tell them to breathe in slowly. And then they should hold the medication in the lungs for 5 to 10 seconds. So they're holding their breath for 5 to 10 seconds. And so for infants and young children who aren't able to cooperate with deep breathing or breath holding, we recommend that you just leave the mask on their mouth and nose for 5 to 6 normal full breaths in and out to allow complete emptying of the chamber, of the medication in the chamber. So sometimes I recommend that the family sing Twinkle, Twinkle, Little Star. And when the song is done, then they can take the mask off the mouth and the nose. So now that's just for 1 puff. And then generally we're prescribing 2 puffs at a time. So then wait 15 to 30 seconds between puffs, shake the canister again, and then repeat what we just reviewed. So don't load both puffs into the chamber at one time and then breathe in once. You're going to repeat this whole procedure 2 times. Now, the inhaler contains a low-dose steroid medicine, sometimes called a steroid glucocorticoid. So we recommend rinsing the mouth and gargling with water after use, and then spitting out the water and not swallowing it. And the spacer can be used for more than 1 type of inhaler. Just remove the first inhaler and insert the second one. So the very best way to manage asthma is to try to prevent asthma symptoms before they begin. Avoiding or eliminating triggers, things that might make asthma worse, is very important. It's also important for the child to use their controller medicine every day or as instructed by their doctor. If their asthma is well controlled, the child will not have asthma symptoms or have to use their quick relief or rescue medicine like albuterol very often. The goal of asthma treatment is to prevent symptoms when possible, act quickly if symptoms occur, and keep symptoms from getting worse. So what are the goals of asthma control? They include not having any difficulty breathing, wheezing, or chest tightness, participating in normal activities, including play, sports, exercise, or other school or daycare activities, not having any coughing, no waking up at night because of asthma symptoms, no missed school days or activities, no missed time from work or other activities for the parent or caregiver, no emergency room doctors visits or hospital stays, and normal or near normal lung function. So in other words, once the asthma is controlled, every child with asthma should be able to run around, play, and learn completely normally. So other goals of asthma treatment. So the child's medical team are obviously experts in asthma, and the parent and guardian know their children best. But as you know, you see their child every day, and for a large portion of the day, you may see things that parents may not be fully aware of. So you can partner with parents to make sure medications are working, or if there are any problems like side effects. You're also the one who will know if the medicines are working or if there are any, the side effects. And lastly, no treatment or prevention program can work unless it's carried out correctly. So again, it's easy for us to prescribe the medication in the inhaler, but the parents need to talk to the school staff, make sure the inhaler and spacer is being used correctly. There's medication in the inhaler, and identifying the child's asthma triggers. And asthma control truly takes a partnership. So what are areas we need to focus on to improve the care of asthma in schools? We need to improve communication amongst patients, families, clinicians, and school nurses to better convey asthma management plans. And these barriers in communication result in students often not having the access to asthma medications at school. The lack of communication resulting in schools having needed asthma management plans at school that convey step-up asthma management. So it's just important to have these asthma action plans at school. So in case these children are flaring, the school staff knows how to proceed. And the lack of communication results in schools being, being unaware of asthma triggers that may affect the condition of individual students. So despite significant research advances in our field, childhood asthma morbidity still just remains very high. According to CDC data and recently published literature, asthma affects 6.8 million children, with 36,000 children missing school every day due to asthma-related health reasons. And children with asthma miss 3 times as much more school compared to children without asthma. And these missed school absences can then initiate a sustained cycle of reduced academic achievement. So Dr. Robert Lemansky is a very well-known asthma researcher from UW who is officially retired but is still active in our asthma world. And a few years back, he was the president of our National Asthma and Allergy Society. And his initiative during this presidency was to create a school-based asthma management program. He and Dr. Sujani Kakamanu developed SAMPRO, which is this program. And the foundation of SAMPRO is the circle of support that establishes strong communication network amongst the clinicians, the families, and the school nurses surrounded by around the child. I don't know why these slides are just having a life of their own. So SAMPRO has actually received widespread endorsement from the American Academy of Pediatrics, the American College of Allergy and Asthma and Immunology, the American Thoracic Society, the National Association of School Nurses, and the American Academy of Allergy, Asthma, and Immunology. So you can see that it's been very well vetted. And the key to SAMPRO is the coordinated adoption of 4 key components. One is establishing the circle of support. 2 is developing and sharing the standardized asthma plan. And 3 is developing a comprehensive asthma education plan for parents, schools, and families, and empowering schools to assess the school environment for asthma triggers and employing trigger mitigation strategies. So the first component, again, is to establish a circle of support among the clinicians, school nurses, and families centered around the child. So this is the circle of support. And each member of the circle of support plays an important role in managing the child's asthma care. And key to the SAMPRO initiative is strong communication network among all the members of the circle and the recognition of the school nurse as an integral member of the healthcare team. So the SAMPRO workforce has developed individual checklists for clinicians, families, and schools to help ensure each member of the circle of support completes the necessary steps to coordinate the child's asthma care. And these lists are available for download for free through the SAMPRO toolkit. And it's available here. And again, I'll circulate all these resources after this lecture. Component 2 of SAMPRO focuses on developing asthma action plans for schools, in particular, developing an individualized asthma plan for each child with asthma. And it's recommended that these asthma plans that are created in the doctor's offices should be shared with the schools, along with authorizations to release health information to the school staff and nurse, so they can administer medications at school if needed. And the third component of SAMPRO advocates for a comprehensive asthma education plan for patients and all school personnel. And this plan should include instruction on what is asthma, management of asthma, and recognizing asthma symptoms and exacerbations. And this, is exactly what we're doing today in this visit. And so again, thank you all for joining. So there are so many asthma education programs available nationwide, and the links to these programs are available within the SAMPRO toolkit. And asthma education should be integrated everywhere and should be delivered in clinics, hospitals, home, and at school. Asthma education should be approachable and available to all levels of health literacy, and it should address multicultural beliefs. And I'll briefly show you a few programs in the next slides, but this list is not exhaustive. I encourage you to look at the SAMPRO toolkit. And other point is that none of the programs I'm showing you are targeted specifically to preschool age children. So this link is actually very helpful as well. These are asthma research. This link is from the CDC, and it's specifically a website made by the CDC on asthma resources for schools and childcare providers. So the American Lung Association developed this validated program called Open Airways for Schools. It's the most commonly utilized school-based asthma education program. It's available for free, and it does require adapting the curriculum depending on the audience, depending on the ages and the students. And here is a link for this program. And again, it's an interactive approach to asthma self-management education. So this is for the children themselves, and it covers warning signs, trigger avoidance, decision-making skills, and it uses methods like storytelling, games, and role play for children. Fight Asthma Now is a validated asthma education program out of Chicago. It has had significant gains. It's shown significant gains in asthma knowledge with inhaler and spacer technique. This program is geared towards children 3rd to 6th grade and teen programs. And again, there are this many sessions conducted on 4 consecutive school days. There is a cost to this and information at this link. Iggy and the Inhalers was developed by a pediatric allergist who trained here in Madison and had asthma himself. So he himself drew all the comics, and this program has been validated in Midwestern School District with significant improvement seen in the students' asthma knowledge. This is a fun way where there's a comic book for children and playing cards, and this program is shown to increase asthma knowledge when there was a test 1 month after the education was performed. Several online resources are available for children. So again, some information here, and all this will be shared with all the participants today. And lastly, this is an 11-minute video that I created along with one of our allergy fellows a few years ago, who's now an allergy attending herself. This is an 11-minute video on for asthma education that we use in our allergy and asthma clinics at UW for parents and children. And the link to the video is accessible to everybody, and it's free. So this is the link, and then you just scroll all the way down on the website, and this is what you'll see, and you just click on this, We Breathers, and it'll start that 11-minute video. Component 4 of SAMPRO includes a comprehensive assessment and remediation of environmental asthma triggers at schools. So this is including assessment of indoor air quality and common allergens and asthma irritants. And this can be initiated at every school to prevent unnecessary illness and school absences due to asthma. So there's this indoor air quality includes exposure to pests, airway irritants, and common allergens. And indoor air quality programs like those available through the EPA can improve indoor asthma quality in schools. So to be most effective, the commitment to assess and reduce asthma triggers from schools should involve all the relevant school personnel, which are all listed here. And the EPA indoor air quality programs are available free through the EPA website, which is right there. And these resources can help to identify and solve and prevent indoor air quality problems that flare asthma symptoms. So in addition, the EPA indoor air quality protocol, there's a mobile app that can help school staff conduct a walkthrough of the school buildings. And this is free, and will just guide school staff on what improvements can be made. Next, I'd like to share with you other available resources to us in our state. So the Wisconsin Asthma Initiative is funded in part by the Wisconsin Department of Health Services and Division of Public Health through a CDC prevention agreement. And we're really lucky to have this statewide school and child care walkthrough program. Their goal is to decrease asthma symptoms in children by reducing common environmental triggers in all places, schools and home. And what they'll do is they'll come spend time assessing rooms and areas and recording identified triggers. And they'll even provide these air quality assessments because they have a partnership with the EPA. They also provide basic asthma education, and they'll recommend low or no cost strategies to remediate any issues that are found. And a follow-up evaluation is conducted at 3 and 12 months for the center to provide feedback on the program. This program is even available virtually now because of the pandemic. So that's been, a positive. The walkthroughs are available at no cost and are completely non-punitive. This walkthrough feedback is not reported to any outside source. It's just available to help the schools and their students. And I've listed the contact here on the slide if you'd like to utilize their services. And again, they even do home walkthroughs and can be recommended to families. And the home walkthrough and the information that the families would receive would be pretty individualized. So in order to access the SAMPRO toolkit, you can download the toolkit here. Registration is free. All this information is free. The toolkit's been created in conjunction with the University of Wisconsin. We do require registration just to access the tools so we can gather information on who's using the toolkit, and we can disseminate future updates. This is the current version, but it's actually currently being updated. So this current version was developed in 2016, and the new version, which will be coming out soon at the end of this year, is going to be called SAMPRO 3, because it's now going to include food allergies and anaphylaxis at schools. So our National Allergy and Asthma Association is working with the American Academy of Pediatrics and their Council on School Health to expand food allergy resources across to schools across the United States. So please stay tuned for our new version as well. SAMPRO acknowledgements are to the SAMPRO workforce. This was a huge initiative and lots of contributors, and the slide Some of the slides for the SAMPRO were developed by Dr. Kakamanu and Dr. Rob Lemansky. And these are references for SAMPRO, and some of the information presented today was adapted by print materials by the Asthma and Allergy Foundation of Asthma. So this is all I have today, and I'm thank you again for taking the time out of your day to listen to me speak, and I hope you found it helpful in understanding what asthma is and what makes asthma worse and how we treat asthma, and I'm happy to take any questions.
Thank you so much. That was a really lovely presentation, and there's some questions queued up that we'll get to in just a second here. I wanted to make two comments though, and then highlight a few big takeaways that I was scribbling notes as you were speaking about things that stood out to me. One is that SAMPRO, even though it seems like it's aimed at the K through 12 system, because of course most early childhood educators don't have access to a school nurse, there's nothing saying that it can't be used in those settings as well, correct?
Correct, absolutely.
Yeah, because asthma is asthma. It's a little different with the younger kids in terms of their developmental abilities, but it's still asthma. And I think a lot of the resources that you highlighted are, again, even though they're aimed at older kids, I think they're also great tools for staff to learn more about asthma themselves.
Absolutely.
Yeah. And I was very pleased to see Iggy and the inhalers. Dr. Thomas, who created that, was just a year behind me in residency, and and I remember
his work on it.
Many conversations with him about that, and so on. Also, the Wisconsin Asthma Coalition, they were a side-by-side program to my early literacy Reach Out and Read program within the Children's Health Alliance. And I'm embarrassed to say I didn't know that they do walkthroughs, and that walkthrough is indeed available to child care centers. So
it sure is. And I do think that it's underutilized. So I like to advertise it every time I give a local asthma talk. And again, it's statewide. So please utilize it. It's an amazing resource that we have.
Yeah, and again, no cost, non-punitive. So
correct.
Really, that's lovely. So I wanted to highlight a few of the things that I think are important takeaways that I think sometimes get missed, and then we can move on to the amazing questions that have come in. One is that all children with asthma should have an asthma action plan. So if you're getting a parent coming in saying, hey, my child has a diagnosis of asthma, or they're shoving inhalers at you in a Ziploc bag, a great question, I think, is to say, that's wonderful, thank you. Where's the asthma action plan? Were you given one? And if not, say you might want to use one, please, so that we have guidance on this.
Thank you for saying that. Yes.
Number two, if it is that metered dose inhaler, the puffer, as many people call it, always use a spacer every single time.
Yes, I always recommend a spacer.
Chronic cough might be asthma. So if that kid's been coughing for quite a few weeks straight, you might suggest that to the parents to look into.
Those are the ones that really get me in clinic, because I know I get the story, just like I said, they've been to the urgent care or emergency room several times because they don't have those obvious, asthma symptoms of shortness of breath and wheezing. That doesn't mean they don't have asthma. So yes, and this is where exactly, these early childhood care providers, they're with children, during those daytime hours, and they're probably seeing it and hearing that cough. And so it might be worthwhile to mention it to parents.
Yes, exactly. And then finally, if we effectively treat the asthma, kids can have a normal life. I think
100%.
Asthma and they can't play and jump, or they're coughing easily or wheezing every time, we should not be saying, oh, well, that's just their asthma. We should be saying, hey, this is something that's controllable, and bringing that up with parents and asking them to bring that back to their primary care medical home for evaluation and treatment, because there's no reason we should be saying that on an ongoing basis.
I've had parents tell me when I first met them that, their child just looks out the window and they can't go outside and play with the other kids because of their asthma. And that just breaks my heart. And we kind of just start from the beginning, and I explain to them that we're going to get their child outside.
Great. I want to go to some of these amazing questions that have been coming in. So first of all, is cough variant asthma treated the same way as other types of asthma?
It sure is. Yeah.
Yeah.
Yep, with those inhaled steroids and albuterol. Yep. Great
Yeah.
question.
With infants especially, how quickly can we help during an asthma attack? They're thinking of kids under a year old. And I think that it's like if they seem to be having an asthma flare and they have medications and all at hand, how long until they should see some sort of improvement?
So it's a good question. So, with infants, there are also, this is if the child has a known diagnosis of asthma. There are also viral infections that may look like asthma in infants that are under a year of age. So, just to think about that. And if they're working hard to breathe, the parent should be informed and the family should be seeking advice from a doctor. But these rescue medications should work if the child under a year of age has a diagnosis of asthma and has been prescribed a rescue inhaler like albuterol. It should work just like it should for an older child. So we recommend, again, just 2 puffs, maybe even 4 puffs, and within 15 minutes, you should see some improvement in their workup breathing.
Yep, and that's where that asthma action plan is going to be important because it'll tell you how many puffs to do. Everything will be laid out there. Yeah.
Yes.
This is a great one. What is the purpose of using a spacer as a separate spacer and an inhaler instead of some sort of all-in-one system? Why do we have it come?
That's an awesome question, actually. Maybe we need to invent one. And thank you for that idea. I think I don't know that the pharmaceutical companies have I don't know that has been a priority for them, but yeah.
There's a steroid inhaler, and the name's not coming to me for which one. I don't think it's on the market anymore, which had this little pull-out spacer that you swung into place. But that's the only time I've
Huh. I haven't seen that, but I don't doubt that it's there. It's an excellent question. And, I think just thinking about this actually a little bit more, there are different size spacers, and that's probably the reason the spacer needs to be matched to the size and the ability of the child. And so there are spacers with a mouthpiece that just goes, that the child makes a seal around with their lips, and then other chamber spacers that have a mask for children that aren't old enough to make a nice tight seal with their lips. So it's probably that's probably one of the main reasons.
Yeah, because it's the same inhaler with all these groups, but being able to switch that out.
Different sizes. Yeah.
You mentioned this, but to clean the air chamber, I think people may have been a little confused about what you said about the soapy water and all. Could you reiterate?
Yeah, sure. Happy to. So it's actually, if the aero chamber is just rinsed in water, there are some electrostatic charges that interact with the medication. And so the first 10 to 20 puffs of the medication won't actually be delivered to the lungs. So we recommend washing that chamber in soapy water, and not, generally when people are washing things with soapy water, then they do a final rinse with water. And I'm recommending avoiding that, just washing with the soapy water.
And just letting it dry in there.
Correct.
Yeah, I don't think that's intuitive for more people. So
it sure isn't.
What age can a child be diagnosed with asthma? And I'm going to add on to this. I don't. You probably heard this as well. I hear it all the time in primary care and urgent care settings. Well, he's not been diagnosed with asthma, and then they're waving a steroid inhaler at me and an asthma inhaler, inhaler, and all these things. And I'm thinking to myself, yeah, your child has asthma. Maybe demystifying that question.
Yeah.
Doesn't have a formal diagnosis. Well, but
Yeah, I hear you completely, and this comes up often. And so per the NIH asthma guidelines, there are recommendations on treatment for asthma with children that are 0 to 5 years of age. So there's no specific age. What I tell my patients is, so oftentimes patients come to me as a specialist saying, my doctor told me that my child can't have asthma yet because they're too young. And exactly, you hit the nail on the board there, Dr. Novsaria, because what I tell my patients is that if they're on asthma, if they're using asthma medications, they have asthma. And it, and childhood asthma is very common, and not everybody who has childhood asthma will have adult asthma. So I don't want families to go home. And I sometimes talk about this, depending on how the anxiety level of the families, but I don't want them to think that the child is going to be on asthma medications for their entire life or indefinitely. We are reassessing these children every 3 to 4 months. And, my goal is for children not to be on any medications they don't need to be on. And so we try to step down depending on, how they're responding, if they're improving, their risk factors, et cetera. So I'm going off a little bit on a tangent here, but so to answer this question again, any child can have asthma, it's really based on this history. So on how the child is doing with coughing, wheezing, how they're handling their colds, how they're handling triggers, and they can be diagnosed with asthma.
Great. Last couple of questions I'll try to, pull together here because I think clearly asthma is something that really so many people wonder about. And so I'm so glad we're doing this today. Are there medications that a child with asthma shouldn't take in general? And they're thinking of like over-the-counter cold medications and things like that. And then on the flip side, is there anything other than medication that is known to help children with asthma?
Great question. So yes, cough suppressant is something that we don't recommend for asthma. It's not effective, and too much of that can also cause adverse side effects. However, on the flip side, there have been studies to show that warm water and honey can help cough. So it's not actually going to help asthma or do anything for the inflammation in the airways, but it may be a non-medication way therapy that parents can employ at home and kind of just help with this persistent cough. But again, the only medications that we know of that help asthma right now are these inhaled steroids.
And are there things other than medication that can help asthma?
Other than medications, not to my knowledge. Yeah.
Yeah, there's some claims out there, I think, with some of the integrative therapies and all, but there's and even our integrative medicine folks will generally say, please take the asthma medications, and you can try these things. So
yes.
Yeah.
The goal is to reduce the asthma attacks and the asthma flares. And remember, with asthma attacks and asthma flares, children are prescribed oral steroids. And at the end of the day, we want to limit the courses of oral steroids. So we want to control their asthma.
Great. And then really quickly, somebody asked, can certain food cause asthma? I think that's only if they're allergic or sensitive to it in some way, but unlikely.
Correct. If there's a known food allergy that results in obvious allergic symptoms within minutes to 2 hours of eating the food, then sure, but it does not. Specific foods don't cause asthma.
Yeah, and I think that it's so important that parents should and caregivers of all kinds should realize nothing you did caused the asthma, right? This is not anything that made this happen. This is bad luck. Well, thank you so much. There's a lot of there's still questions flowing in, and I'll try to address a couple of them quietly in the chat here. But thank you so much for your time and expertise today. And I'm going to hand it back over to Maria.
It's a pleasure to be here.
Thank you.
Well, as we wrap up our time together, we are here to help answer those health and safety questions within early childhood care and education settings. Our program is titled Early Childhood Health Consultation, and we offer not only webinars such as this one today, but also on-demand resources found on our website, tailored health consultation in target pilot locations, as well as our recent launched podcast titled Teachers, Toddlers, and Tissues. Feel free to listen to our trailer in episode 1 right on our website or on your favorite platform. We also, in a moment, will drop in the chat our contact information. Please reach out via phone, email, website, or social media. We'd love to connect. We'd also like to say a special thanks to the many early childhood care and education providers that help us support the best needs of our programs, including our very own advisory board. We like to also say thanks to our project partners, our project team members, as well as the colleagues who work in childcare health consultation across the United States. Following the webinar, we invite you to fill out our post-webinar Qualtrics survey link, which will be dropped in the chat. This is a great place for you to offer us feedback on continuing how do we improve our webinars, and a space for you to enter your information if you're interested in continuing education credit with the registry. Following today's webinar, you'll receive an email with a webinar recording, as well as a link to the survey. For those who enter their information with the survey, we will enter your attendance directly with the registry following the webinar. Finally, our webinar recording will also be made available on our website. Save the date for our next webinar, May 4th from 1 to 2. Learn more on our website. Okay, feel free to reference the chat for that link to the Qualtrics survey. And we'd like to say thank you for your time and attention in today's session. Dr. Nazaria, any closing remarks?
No, just to say again how much we appreciate all of you being there. I just put the stuff in the chat. Sorry, I was responding to some of the great questions coming in. So again, that's how to reach us. And please make sure you fill out that survey link. It helps us develop better programs and also helps us address being able to get you registry credit as well. Thank you again to our speaker today and to all of you for the great work you do.